Okay, at the same nursing home where the triplets fell, this patient was noted for a sodium of 172. Well, what the heck is that? Well, let's talk about it. Is why do patients get hyponatremic? Who are these patients? Well, it's mainly going to be elderly patients who can't care for themselves. It just basically is usually a lack of free water. Hyponatremia can be very difficult to figure out and could be vexing for a provider, but hypernatremia is pretty easy, is they're not getting free water. And why does it happen in nursing homes? Simple word, money and staffing, 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 staffing. Remember, these nursing homes run very narrow margins. They run very lean staff, and the staff they get may not be the greatest in the world because they have low funds to pay for it. Now, treating hypernatremia. Now, the old maxim was 6 to 12 milliequivalents per liter. This is going to be in a 24-hour period. 6 to 12 milliequivalents. What can happen if someone's with this hypernatremia is mortality, cerebral edema, seizures, alterations of consciousness, altered mental status. So the maxim kind of changed back in 2019. And why didn't you hear about it? Well, kind of what was going on was COVID. And COVID kind of took away a lot of other studies that came up during that time period in the initial, because the world's eyes were watching COVID. There was other studies that happened to be popping up. So in rapid correction, there was no difference in mortality between the groups on rapid versus slow correction of hypernatremia. And then on follow-up studies, the trend for lower mortality in admission hypernatremia with rapid correction, because they had shorter hospital stays. In shorter hospital stays, they had better outcomes. All right, let's go to this patient. It's a 47-year-old, noted for a BP of 210 over 110, noted for seizures. Okay, so let's talk about the etiology of this, that this patient has hypertension and they have seizures. Now, let's think about different times. So what if they were in a hospital and they had a procedure done and this is 48 hours? What will we think about? What could it possibly be? We're using the magic time, 48 hours. He's been in the hospital. Remember, no one drinks, do they? But they do, okay? So remember, 2022 alcohol sales in the US reach about $260 billion. $260 billion and no one's drinking, right? So let's talk about alcohol withdrawal. Is a war, and we're going to talk about two systems in our brain that are kind of at war in alcohol. It's the GABA and the glutamate. And the GABA system is our suppressing. This is where benzodiazepines kind of hit. This is where alcohol hits. Glutamate is more of our excitatory system. Now, unless you're insane, maybe you are, or you're a hospital administrator, you should be in balance. If you're a hospital administrator, you're never in balance, right? So we have our GABA system, our suppression, and we have our excitatory. And you're not running down the streets naked, hopefully, so you're in balance. You're in balance. So what happens to GABA after we take alcohol? So you have your receptor sitting here on the surface. You have your receptor sitting here in a glutamate. So what happens is you take alcohol, we take alcohol, and it hits the GABA receptor. So the body's trying to be efficient, and goes, hey, you know, we're having all this alcohol coming in here. We really don't need to be here, so why don't we take a break? So the GABA receptors downgrade themselves. They downgrade themselves. And everything's good because you're drinking daily, okay? So you're giving the GABA, you're suppressing your glutamate, everything's in balance. But you're drinking too much, and you're having the side effects of alcohol, and then eventually you stop drinking for one reason or another. Maybe you get sick, maybe you broke your leg, you can't go to a liquor store, maybe you get a very bad cold, flu, etc., or diarrhea, and you can't go to a liquor store because they don't want you in there with the diarrhea, okay? So you can't go to a liquor store, so suddenly you stop the GABA receptor. Whatever was hitting your GABA receptor, you stop. So what happens? Your glutamate system takes over. When your glutamate system takes over, what happens is you have tachyarrhythmias. You have these tachyarrhythmias, and what can happen? Death. That's what can happen. So if you suddenly stop on the GABA side and you have the glutamate side, you're not in balance anymore, and the result can be death. So what can we use to predict alcohol severity? There's different things. There's this PAUSE model. It's a prediction of alcohol withdrawal severity scale. It's a validated clinical screening tool designed to identify hospitalized patients for risk of complicated alcohol withdrawal system. Includes several manifestations such as seizures, during tremens, or withdrawal hallucinations. Now, I want you to remember something. Vitals are vital, especially in alcohol withdrawal. What are the first things you see? Increase in temperature. What else? Tachycardia, okay, hypertension, kind of like our guy in our example. Tachycardia, hypertension, and you can have a fever. So this Paul score is just one example, and you go through and it has a good sensitivity, about 93 sensitivity and specificity of 99.5. And it goes through and basically asks you about several questions, and you can get the scoring, how many times you've been recently intoxicated or drunk within the last 30 days, and it gives you a score on that. Gives you 1 point if you say yes. If you ever experienced episodes of alcohol withdrawal, you say 1, you say yes. You can go through these questions. They're great. But the problem is patients may not tell the truth. Maybe their loved one's in a room and they don't want them to know that they're drinking alcohol. So these are things where we have to be prepared as providers for people who come to the hospital to have withdrawals. So things we want to think about when somebody's having alcohol withdrawal, besides giving them medications that are going to hit the GABA side so that we can get in balance again, get out of the tachyarrhythmias, getting out of the increased risk for death. Thiamine. Why do we want to give thiamine? So we worry about what? With thiamine deficiency is Wernicke's encephalopathy. And that's, how does that show up? Well, say you screwed up and you didn't give them the thiamine, and they go home and they become altered, or they're altered in the hospital. They do an MRI. It's going to show abnormalities in the thalamus, mammillary bodies, tactile plates, in the periaqueductal area. So you'll find these, and they'll make the diagnosis on radiology. Will say that it looks like they have Wernicke's encephalopathy. And then they look through the MAR and they say, hey, how come provider XYZ, how come you didn't give the thiamine? And you said, oh, I didn't know, I made a mistake. And they say, well, you made a mistake, and write your check. You're going to have to work for us now. So these are things you have to think about when you're working on patients. Are they going to go into alcohol withdrawal? Do they have high risk for alcohol withdrawal? Do patients lie? Yes, patients are going to lie. So then, to affect the GABA system, we put benzodiazepines. Okay, so we give benzodiazepines. Examples would be diazepam, chlordiazepine, or lorazepam. These are commonly given. Different hospitals, different facilities use different ones that they prefer more than the others. Plus, you seem to have shortage. Lorazepam seems to have a shortage often. Phenobarbital can also be used, and that's becoming an up-and-comer, where that hits the GABA system, has a longer period of half-life, and it seems to help reset patients better. Basically, you're hitting that until the body's natural GABA receptors grow up, and then you develop the balance between the systems. Clonidine or dexametasone can be used. Clonidine is used for hypertension, but it does a great job in hitting the alpha-2 receptors in the brain. And in some countries, they use this for withdrawal. They use it for withdrawal, for alcohol withdrawal. They can use it for everything from heroin withdrawal. It's very cheap. It does work. Then you're going to have as an outpatient taper, as the patient's going to be tapered outpatient, and then follow up with, looks like now is the GLP-1s. It looks like they're reducing the cravings for alcohol. And then you need to get help. You need to be in an outpatient organization such as AA or another group that will help follow you so that this doesn't happen again. Audit, which is 10 question. This is set up by the World Health Organization. CAGE, this is one you're probably familiar with, and this has been taught in school for many years, is the 4 questions. TACE is 4 questions. This is probably being used more. When was the last time you had 5 drinks in a day? This is for a man and 4 for a woman. Now, if you can get your patients to answer correctly, this will help you understand if you need to do further screening for alcohol use disorder. Now we'll talk about the same patient again. And we're talking, so this patient has gone through a lot of things. Now we run the risk of we get them better and they start eating, as we have a risk for refeeding syndrome. This is when the phosphorus drops below 0.6 millimolars from a previous lower normal level within 3 days of starting nutrition. This is characterized by shifts in potassium, phosphate, and magnesium in the cells from increasing, because we're eating, we're going to increase our insulin secretion, resulting in hypophosphatemia, edema, tachycardia, tachypnea, and risk of cardiac and respiratory failure. See, these patients are going to have high thiamine requirements because their body is going to be deficient. They're going to have a total body deficiency. So These are going to be leading together, so we need to give them phosphorus, of course, thiamine, vitamins, and electrolytes, high doses of thiamine too. Wernicke's encephalopathy could be as present as confusion, delirium, ataxia, and ataxia. Those are going to be the big things. So the classic would be is a story of a patient who has an unhealthy alcohol use disorder and is starting to recover from withdrawal and starting to eat. So they haven't been eating, they've been doing well, they're just focused on alcohol, and then they start eating. You can see in the classic in the movies is the POW or prisoner of war, or someone who's been kidnapped and not fed and has been liberated and is now eating. So what can they be having is double vision, altered mental status, seizures, cardiomyopathy, difficulty breathing. And then remember, phosphorus is used from what? ADP to ATP. ADP to ATP. Phosphorus is being used for that. So that's our energy, our store, that's our fuel. Now let's think out of the box is not so much as this patient who's an alcoholic. Let's think of somebody else who can have abnormal phosphate levels. And let's talk about a patient who has hyperemesis gravidum, meaning they're a pregnant patient and they're not able to keep any nutrition down. If they can't keep the nutrition down, is they have a high risk for refeeding syndrome. And why it's so important for us to think about this is not only with phosphorus is cheap, you can save 2 lives instead of 1. You save 2 lives, the mother and her baby, because of the fact of you just thinking about what's the right medication for this patient and that thinking outside the box. Yes, the person living on the streets drinking alcohol has a high risk for refeeding syndrome, but also the mom who's living in a house in the suburbs who is uncontrollable nausea and vomiting can have refeeding syndrome. All right, so the same patient. I know we're going through a lot of stuff, but this is the real world. And actually, this is a clinical scenario that this patient went through. This is based off our true story. This 47-year-old who's inpatient, who had a procedure, then had alcohol withdrawal, now is noted for, looks like almost seizures, altered mental status, and changes in vision. So what is this? What are we looking at right here? This is actually an MRI picture right here. And this disease is rather a new disease, but what we're seeing here, this is in the posterior, right? We're going to get a little fancy drawing pan. We'll get to the posterior. No, we won't. Okay, so let's get in our drawing right here. And we see in this posterior right here, see that right there, that inflammation? So this is posterior reversible encephalopathy syndrome, PRES. It's a reversible, can be reversible in some cases, majority of the cases. Reversible brain swelling. And it's reversible about 70 to 90%. And what's the symptoms? Headache, confusion, focal neurodeficit, can have seizures. This guy already had seizures, got better, and then has seizures again. Visual disturbance, hypertension, altered mental status. What can cause this? Not perfectly known, but patients who are immunosuppressants, chemotherapy, who are on certain stimulants, or an antiretroviral therapy have a higher preponderance for this. So this is kind of a newer diagnosis, 1996, and it has to be seen on MRI. You can see them on CT scan, but that's extensive bad damage. It normally usually is diagnosed on MRI. So it's a vasogenic edema secondary to endothelial dysfunction. So endothelial dysfunction, the blood-brain barrier dysfunction. So blood-brain barrier dysfunction, and you have endothelial dysfunction. The hypertension causes vasospasms, local ischemia, and blood-brain barrier dysfunction and vasogenic edema. And you can have loss of vision with this because you have swelling in the posterior nocipular region where our brain comprehends and sees. So that can cause loss of vision on there. Now the posterior circulation, lack of sympathetic tone for the vertebral arteries and basal artery and the posterior cerebral arteries allows this to happen when you can have PRES. All right, and let's discuss a hypertensive emergency in this discussion with the same patients. Patient's been through a lot. So seizures, alcohol withdrawal, PRES, and then risk for refeeding syndrome. So a lot of things can happen in the same patient. So hypertensive emergency can be defined as SBP greater than 180 and diastolic blood pressure greater than 120. I know that people will tell you that hypertensive emergency, and I see the literature where it doesn't exist. It does exist, especially when we're talking about this, is we need to have altered mental status. We have end organ damage. Just like we talked about the poor perfusion in the cardiology section, initial part of cardiology section, we have the same thing with the hypertensive emergency. We have forms of end organ damage with altered mental status, elevated troponin, hematuria, proteinuria. So the kidneys got hit on that one when they're having hematuria and proteinuria. So what medications can we use? Nicardipine, labetalol, captopril, esmolol, sodium nitroprusside, clevaprine. So let's talk the same patient. In the same patient, I know this patient is getting old, but here again is that this is the real world. So this is a 47-year-old. He came in and he had a procedure. Then 2 days later, his pressure shot up to 220/110. Noted for seizures and is suspected secondary to alcohol withdrawal. He was at risk for refeeding syndrome because he hasn't been feeding himself. He had low phosphates. Then noted for hypertension again and loss of vision, kind of seizure-like activity, altered mental status. He gets PRES, posterior reversible encephalopathy syndrome. And then we also talked about the alcohol withdrawal. Now he's noted for this. What is this? Now we're back to our cardiology. So yes, we took a long voyage and we're still on our cardiology. What is this right here? This kind of point of inflection. See that right there? So we have what looks like VTAC, right? But it's not only through maybe VTAC, a little VFib, and then kind of we have like a little, like say, reset point. So what is this? This is torsades de pointes. This is a specific form of polymorphic ventral tachycardia that occurs in the setting of a prolonged QT interval. It can be either congenital or acquired, the QT interval prolongation. We'll talk about where you can look at what medications cause QTC prolongation. It is characterized in EKG by distinct twisting. We can see the twisting here. You can see the twisting across the screen of the QRS complexes around the isoelectric line with waxing and waning amplitude, and typically presents with recurrent self-terminating episodes that may cause syncope to progress to ventricular fibrillation, and guess what? Death. So what medications can cause prolonged QTC? Well, there's a wonderful app website, and it's for free, and it's for providers called Credible Meds. And it gives you a list. It gives you a list. Now, what's common things? Antiarrhythmics can do it. Remember, they're fixing the rhythm, but they can cause arrhythmias. Antipsychotics, macrolide antibiotics, hypokalemia, hypomagnesia, hypocalcemia can. Structural heart disease can do it. So one is a prolonged QTC. Now you can go by the technical definition, but probably what the real world definition would be is greater than 500. 500 on the QTC. Now what's the treatment? We're going back to torsades. What is the treatment for torsades? IV magnesium, 2 grams IV over 15 minutes is first-line therapy, regardless of the serum magnesium level. It is suppressed early after depolarization. So magnesium is one. We'll discuss this too. Magnesium is very hard to measure. It is probably our most incorrect measurement of an electrolyte that we have in our body because so much magnesium is stored in our bones and it kind of fluxes in and out rapidly. So magnesium is usually incorrect. So, but if we see this rhythm right here, this torsades, we don't go, all right, let's get a magnesium level and we'll wait till it comes back. You can wait till it comes back and then you can give the magnesium level to the funeral home because the patient's going to be dead. So this is where you treat the patient. You really don't worry about the levels at that time because you clinically suspect that this is torsades and the treatment would be magnesium. All right, let's talk more about torsades de pointes. Rate usually between 150 to 220 beats per minute. P wave obscure if present. QRS can be wide and bizarre. As you can see, it kind of goes all over. Its conduction, as with PVCs, rhythm is irregular. It can be proximal, starting and stopping quickly. Hallmark of this rhythm is the upward and downward deflection. We saw that twisting. Remember, torsades de pointes means twisting about the point. So caused by, we talked about medications that prolong the QTC, electrolyte imbalances, myocardial ischemia can also do it. Treatment is cardioversion, IV magnesium, IV potassium to correct the electrolyte imbalance, and sometimes you may need to pace them above the rate to slow it down. Now, why does magnesium work? It acts as a calcium channel blocker. when treating torsades by blocking calcium channels. Magnesium both decreases the calcium influx into the bronchial smooth tissues and competes with calcium to calmodulin. But blocking the calcium's ability to activate the actin-myosin cross-bridge cycling, this leads to relaxation of the smooth muscles and bronchial dilation. So that can be used in asthma, but it's going to relax our tissues basically. The same mechanism treats bronchospasms in asthma, and it prevents seizures and eclampsia. So acts as a calcium channel blocker for treating. And what do we use IV magnesium can be used for? We talked about torsades, bronchospasms in asthma, and then prevents seizures and eclampsia. Consider VTAC if it doesn't respond to antiarrhythmic therapy or treatments, meaning that you give the magnesium and we still have that same rhythm.